because I have two topics to discuss, so the earlier the better. Assalamu alaikum. Good morning. Assalamu alaikum. Good morning. So I want us to start because I have two topics to cover. Okay. So we start off with prostatitis. Is the second slide on? Okay. Thank you. So we start off with prostatitis. By the end of the discussion, these are the things I expect you to know. You should be able to give a definition. Now, as you must have realized with my lectures, I don't expect you to cram anything. Rather, you should know those features that constitute the definition of the clinical condition that we're discussing, okay? So I don't expect you to start memorizing something, but you should be able to say, when you're defining a condition, you should be able to say the characteristic features that define that condition. Is that clear? You discuss the presentation. I'm not going to go into the clinical details. I'm not the clinical faculty. My talk is also going to focus on the laboratory diagnosis in terms of the specimens that you collect and send to the lab and how you interpret the results. Then the management guideline, again, I'm not going into specifics. Okay. So when we say bacterial prostatitis, because bacterial agents are the leading cause of prostatitis, there are certain features. So you have the presence of the pathogenic organism, and there's evidence of tissue response. So you have inflammatory response. Those two components define bacterial prostatitis. Is that clear? Now, in terms of presentation, there are 4 classifications. So you can have acute bacterial prostatitis. From the word acute, you know it must have a sudden onset, okay? Then you have chronic bacterial, chronic prostatitis or chronic pelvic pain syndrome, and you have asymptomatic prostatitis. As a clinical condition, prostatitis is very rare in young males. So if you find, say, a man in his 20s, 30s, and he has that diagnosis, think of a sexually transmitted organism first, okay? Because it's rare for you to find this condition in young men. The acute form typically is characterized by a sudden onset of fever, tenderness, as well as urinary and constitutional symptoms. With chronic prostatitis, there are just a few symptoms that the patient will present with, and it represents a recurring infection with the same organism. So the patient must have been presenting to your clinic repeatedly, and each time we send the urine sample to the lab, it's always the same organism, okay? So that's chronic prostatitis. Sexually transmitted infections, which include gonorrhea, chlamydia, and ureaplasma urealyticum, have been implicated in prostatitis, as I've said earlier, in young sexually active men and in those who have HIV. Other microbial agents such as fungi, mycobacterium, tuberculosis, and viruses are infrequently associated with the condition, particularly when you have immunocompromised hosts. Because they are immune compromised, any other organism may become a significant pathogen in this situation. But if you have an immunocompetent male patient, you won't be thinking of fungal agents. Okay, is that clear? So what are the risk factors? So the highest risk factors are, as listed here, benign prostatic hypertrophy results in some form of obstructive uropathy. So it allows organisms to replicate. So you can have invasion of the prostate, genitourinary infections, high-risk sexual behaviors, history of sexually transmitted infections, urodynamic studies. The patient came to the clinic and you had to do some contrast investigations, but maybe your contrast medium was contaminated and then the patient ended up with prostatitis. In immune-compromised patients, we said that anything can become a significant pathogen in this group of patients. At times, prostatic manipulation, having, as we're going to discuss, at times when the prostate is inflamed acutely, you're not supposed to massage it because you cannot have a disseminated infection. Performing cystoscopy or a transrectal biopsy, or when you have urethral strictures, all these are known risk factors that could lead to prostatitis. In terms of pathogenesis, there are different access routes to the prostate. Organisms may access the prostate gland through the ascending routes, just like we said with UTI, okay? You may have hematogenous spread, or you can have direct inoculation because of the procedure you were carrying out, for example, a transrectal biopsy. In most cases, bacterial prostatitis occurs secondary to acute or recurrent UTI. Less commonly, epididymitis, urethritis, or infected prostatic calculi may be a reason why the patient came down with the condition. Men with chronic indwelling catheters as well as uncontrolled diabetes who are immunosuppressed are also predisposed to developing prostatitis. And that's because the foreign body, remember we discussed CAUTI yesterday, you can have biofilm formation. So this serves as a reservoir for organisms that could potentially invade the prostate. Hyperglycemia and impaired immune responses favor the exponential growth of microorganisms. Just like we've been discussing since the beginning of my discussion with you, Escherichia coli is also top on the list of microbial agents that could cause prostatitis. However, the gram-positive organism, Enterococcus, is also a significant organism to consider when you have patients with this condition, okay? So this table gives you a summary of the clinical presentation, the diagnostic test, and the therapy for prostatitis. Now, remember we said based on clinical presentation, we can have 4 clinical classifications. So we have the acute bacterial, and the chronic pelvic pain syndrome, and asymptomatic prostatitis. So I want you to focus on the symptoms and the physical examination. I want you to note that when you have a patient with suspected acute bacterial prostatitis, you do not massage the prostate gland. So now this is my main discussion, laboratory diagnosis. The diagnosis of the acute condition depends on the patient's clinical presentation and the presence of significant bacteriuria. So as with other UTIs, the infecting organism can be isolated from midstream specimen. However, when you have a chronic condition, diagnosis becomes more difficult, okay, relatively to the acute presentation. So the patient presents with history of recurrent UTIs. Remember, we said a feature of the chronic one is it's still the same organism. Then the patients, then with chronic prostatitis, again, the clinical presentation can vary from patient to patient, okay? So in order to help you make a laboratory diagnosis, urinary tract localization studies are very important. So what does this mean? Localization is an English word, right? What do you understand by the word localize? to identify the particular location or spot. Okay, very good. Now, before we discuss the how you carry out the laboratory test, I want you to know that the E. coli, usually associated with chronic prostatitis, has a higher virulence factor and a greater degree of biofilm formation. So this could explain why the patient presents with recurrent UTI. And I hope you read the article I gave you in further reading that discusses all the virulence factors of uropathogenic E. coli. You didn't. You should. You should. Because I can't discuss everything within 1 hour. Okay, so we talk of localization culture or localization test, and we further qualify the test by saying quantitative. So what does that tell you? Yes, it gives you a number and the site. Is that clear? So this is an old test. It was described by these two guys, Mears and Stamey. It is regarded as the diagnostic standard. However, it is rarely performed in clinical practice. And the reason, as you'll find out when I discuss it, is because it's cumbersome, time-consuming. Nobody has the time. So what do? The samples you send to the lab, you're going to send 4 glass or 4 tubes. So it's also referred to as the 4 glass test. Okay? Now, if you look at this diagram, you notice that the VB1, VB stands for voided bladder. So that's the urine that's coming out. The initial urine, the initial stream of urine will wash out whatever organism is present in the urethra. So when you collect the VB1, it represents the urethral organisms. Are you following? Then we move on to VB2. As you can see, this is the urine in the bladder. So when you ask the patient to collect a midstream, okay, it's going to reflect whatever is present in the bladder. You assume that the initial 10 mils, okay, has washed out whatever you have within the urethra. So what you collect, after you collect VB1, you tell the patient to continue void about 200 mils. Then you collect VB2. By then, VB2 is representative of whatever is present in the bladder. Now you understand why this is cumbersome. So you give the patient the tubes, collect the initial 10 mils, continue micturating 200 mils. How is the patient going to measure 200 mils? Then collect VB2, 10 mils again. So it's a little bit cumbersome, okay? So the patient collects VB2, which represents whatever is present in the bladder. Then the patient stops micturating. You're going to ask the patient to lean over on the examination couch. You're going to perform a rectal examination with your gloves and lubricants, right? And you're going to massage the prostate gland. So how do you massage the prostate gland? You move from the periphery towards the midline of the gland. So firmly, you're going to milk right and left lobes, okay? And in the process of massaging, whatever secretion, remember it's an inflammatory process, so you're supposed to have some form of maybe purulent collection or what have you. So whatever is present, you're going to milk it out through the urethra. So this is what you have here. So it gets into the urethral portion, the prostatic portion of the urethra, right? And then it comes out. So you have what we call the EPS, expressed prostatic secretions. Are you following? So after massaging the prostate, you're going to ask the patient to go back and give you another 10 mils urine. So that is the post-massage sample, and that's VB3. Now you will notice from the diagram that with VB3, you have these greenish dots as well within the blue urine. Now, what this is telling you is that at times, when you express the prostate gland, you may not get the EPS out through the urethra, but you've managed to push it into the prostatic portion of the urethra. So when the patient goes to void, whatever you milked out into the urethra gets passed out with the urine into the VB3 glass. Are you following? So that concludes the 4-glass test. Now, like you can see from the explanation, it's a little bit cumbersome, right? So what we have, or what is usually done in clinical practice, if you don't send the midstream urine, is that you do what we call the 2-glass test. So this is a modification of the 4-glass test. With the 2-glass test, you ask the patient to collect the midstream urine, okay? Then you're going to perform prostatic massage, and then you collect the post-massage urine, and that's it, okay? So the procedure I just explained, reflecting the volume of urine that you're going to collect, is depicted in this picture. So now, how do you interpret the result? The diagnosis is based on the number of bacteria that you have in the expressed prostatic secretion when you compare it to the initial voided VB1 and the midstream VB2. So you're going to do you're going to do colony count for all the samples. To make a diagnosis, the EPS or the VB3 should contain a bacterial count that is 10-fold greater than that of the VB1 or the VB2, okay? Remember that your VB3 contains prostatic secretions as well. So your EPS and your VB3, the bacterial count should be 10-fold greater than what you have in either VB1 or VB3. So here this table is showing you what happens with all the different clinical presentations that you can have in terms of bacterial culture and the presence of white blood cells. Note that with acute bacterial prostatitis, you're not going to carry out any massage. The midstream urine is believed to be representative of whatever is going on in the acute inflammatory condition, okay? Now, there are times when the urine or the semen cultures do not really help, and the clinician still feels the patient has a chronic pelvic pain syndrome. So other things that you can do includes the 2-glass test. You may want to perform a urethral swab. Maybe you're dealing with sexually transmitted agents. For example, if you have an organism such as chlamydia, mycoplasma, we may not get them on routine culture. So if you send a urethral swab, we can perform culture. Now that we know that we are dealing with non-routine organisms, then we're going to use specific agar in this situation, or we may use PCR. The other tests are not microbiology related, but these are other tests that can help. In terms of management, you need antibiotics. That's why your culture and susceptibility result is very important, and you should also send a consult to the urologist. Complications that could arise include prostatic abscess or emphysematous prostatic abscess. These are not good conditions, and before you know it, you may have a widespread systemic sepsis on your hands. Any questions? Yes. So this is a common thing in areas where this condition is prevalent, because you don't have potable water. People depend on, streams and rivers for their source of water. So by the end of the discussion, should be able to discuss the life cycle. Remember, this is a parasite that we are discussing. So because this is renal block, we are focusing on Schistosoma hematobium only. We're not going to discuss the other species. You should also be able to give the epidemiology of this condition, pathogenesis and clinical features, laboratory diagnosis and approach to management, as well as the complications. So Schistosoma hematobium is a major parasitic infection of the tropical regions. And because this is a parasite that has an indirect life cycle, you have an intermediate host. The presence of the intermediate host means the disease is present in that environment. So you have what we call geographic restriction or distribution. 3 common species from your PhD lecture, you still remember these: Hematobium, Mansoni, and Japonicum. Of course, there are other species not so prominent as this. The resulting clinical condition is referred to as schistosomiasis or bilharziasis. Sorry, I have problems pronouncing this word because the condition is also referred to as bilharzia, or it's also referred to as snail fever. That's to let you know that the locals know that when you have the snails in the environment, you have the disease, okay? From POD, you remember that flatworms can either be cystodes or trematodes. Trematodes, non-segmented, and they're flatworms. And most trematodes are hermaphrodites. So there are exceptions to the rules. And schistosomes happen to be the exception. The eggs of schistosoma species, as opposed to what you have with other trematodes, does not have an operculum. You know, the operculum is that opening through which the juvenile worm is going to escape from. But with schistosomes, what you have are spines. And the location of these spines can help us to speciate the organism. Unlike other trematodes, schistosomes exist as separate sexes. So you have the male worm and you have the female worm lying within the male worm. They are also intravascular parasites, so they are within the vascular system. So we refer to them as blood flukes. Other trematodes are found in other tissues, such as the lungs. When we talk of lung flukes, that's Paragonimus, or you can have the liver fluke and what have you. The infective form can penetrate intact, healthy skin. This is very important because you don't need to have any form of skin pathology for this infective stage to penetrate the skin. Is that clear? The male worm is larger than the female worm and its brother, and it tends to fold over. And in the midline, you have this gynecophoral groove in which the female worm resides, okay? The female worm is the slender worm found within the brother male worm. With S. hematobium, infection tends to occur predominantly along the Nile Valley and many other parts of Africa. The infection is first acquired in early childhood. Then prevalence and intensity of infection peaks at around age 15 to 20 years. Intensity declines with age, and that's because as you get older, you send the kids to fetch water. So you are no longer exposed to the agents. The organism has also been reported in various regions of Saudi Arabia. I've included a journal article discussing this. Schistosomiasis is considered a disease of economic progress, okay? So when you have development of land irrigation project, which is meant to reclaim dry land so you can have better agricultural produce, it often results in the snail intermediate host finding its way there, and then you have the disease. So what is the life cycle like? So what happens is you have a patient who is infected, okay? Now this life cycle picture shows what happens with both hematobium and Mansonite, but we are going to focus on hematobium, like I said. So when this infected person goes to pee, and because you don't have good housing, you don't have good, environmental hygiene, people don't know it's not good to go peeing in the environment. So they go to the river. When you're swimming, you can pee, right? And nobody knows. So in the process, the eggs are released into the fresh water stream or river. So these eggs, because the temperature, the humidity is okay for them, they're going to hatch and release the first larval stage, which is referred to as miracidium for one, miracidia for many. Now, these miracidia are motile. And once they are released, what they do is they actively seek out the snail intermediate host. If they don't find the snail intermediate host, they die off. So this is telling you that in areas where you have this infection, there is concentration of the intermediate host. There is high contamination of the fresh water as well. So when this miracidium invades the particular snail host, it's going to develop further within the snail host, and then it's going to release the motile cercaria. The cercaria are the infective stage of this parasite. So when an uninfected person comes to fetch water, to swim, or wades through the contaminated water, the cercaria are going to penetrate the intact skin. And once they do that, they're going to lose the tail, they are motile. The moment they invade, they become what we call schistomoles. So they are no longer cercaria. They become schistomoles, and they eventually find their way into the circulation, and then they are distributed to the final sites in which you have the adult worm. So with schistosoma hematobium, it's the vein, it's the vein of the bladder. With Mansonite, with Japonicum, these are intestinal strains. So they tend to develop at these sites. The infected individual will now start passing out the eggs, and the entire life cycle is repeated. Now you've got to understand that with schistosomiasis, it's because you have repeated infections, okay? Because the adult worms do not reproduce. So if you have just one adult worm, one adult male and female, that's it. But you can have many due to repeated infection, okay? And once the female mates with the male worm, she starts to produce eggs. These eggs are motile. They're going to find their way through the blood vessels to get to the kidneys, okay? So the pathology associated with this condition is associated with the eggs that are being released by the females. It is not due to the presence of the adult worms. Is that clear? So I've explained this. So the adult female worm deposits eggs in the portal or perivesical system, depending on the species you're dealing with. Now the eggs will migrate to the bladder when we're dealing with hematobium. The eggs are excreted from the infected human host via stool or urine, and the released eggs hatch and release miracidia, which penetrate the snail intermediate host, and the miracidium develops further into the snail, in the snail intermediate host. Subsequently, motile cercaria are produced. So in terms of pathogenesis, like I said, the adult worms are not responsible for the pathology associated with these conditions. Most of the serious manifestations arise from the deposition of the eggs. And you have the formation of granulomata and fibrotic lesions in affected organs. In this case, with the bladder, it may herald malignant changes. So how does the patient present? With schistosoma hematobium, the initial infection, when you have the initial acquisition, there may be dermatitis and allergic reaction because these cercaria are going to produce hydrolytic enzymes. In some patients, there is some form of allergic response to these hydrolytic enzymes. Patient presents with hematuria, usually terminal hematuria. There could be loss of bladder capacity. You know, we said with repeated infection, the eggs get trapped, there's formation of granulomas and fibrous tissue. Eventually, the bladder capacity reduces, okay, because of fibrosis. There could be obstructive uropathy. In women, it's been shown to cause infertility when these eggs find their way into the fallopian tube, and then you have these granulomatous response and fibrosis. There is occlusion of the fallopian tubes. It's also associated with squamous cell carcinoma of the bladder. So how do you make a diagnosis? Because you tend to have what we call terminal hematuria. So the last few drops of urine at the end of micturition are most likely to be reaching over. So when you give the cup to the patient or the mother of the patient, excuse me, tell them that you are interested in the terminal portion, not the initial portion. But this may be difficult. So at times when they come with the urine, you can spin it down. Okay. Now, excretion of the eggs is said to be maximal around midday. Now, some people believe this is because the chances of you swimming at that time or being engaged in water-related activities is higher. So the chances of the parasite accessing the intermediate host is higher. I mean, if it's maximal at midnight, nobody is swimming at midnight, you understand? So it's more of like a parasite-host relationship. You can, apart from performing microscopy on the urine, a biopsy may help. Of course, this is not coming to the micro lab. This is going to the histopath lab. So the eggs can be demonstrated in bladder wall. Serodiagnostic test is available, but this is not useful in endemic areas. In areas where you don't have the infection, this may help you, okay? So how is urine collected? Collection is preferably done between 10 and 2 p.m. We said that, you know, midday you have maximal excretion. It is believed that if the patient exercises for like 15 to 20 minutes, it's going to enhance, it's going to result in more excretion of the eggs. So it increases your chances of finding the eggs in the urine. Is there a reason for that? It's just an observation. At times you can associate certain things without any explanation. I'm not sure there's any explanation. But it's been shown that if you like, you can ask the toddler, no, not toddler, you can ask the young child to walk around or to run around, go up and down the steps, whatever, before submitting the urine sample. The urine is collected in a large bottle. Allow the urine to stand for 30 minutes so the eggs can settle to the bottom. Then you remove the supernatant, that's what is on top. You mix this up, whatever is left after you remove the supernatant, and then you transfer into the specimen bottle, you send to the lab immediately. Now, the gold standard is to demonstrate the presence of the eggs in the urine. As you can see, this is a sample prepared from a patient's urine. That's why you have a lot of red blood cells. Okay, so these are red blood cells, and you can see the eggs. How do I know it's hematobium? Very good, the terminal spine. So this is diagnostic. So how do you manage? Drug treatment. Praziquantel is effective, and it's often used for mass control programs, and it's useful for other species of schistosoma as well. So what are the complications? In long-standing cases, you can have malignant transformation. There could be obstructive uropathy. In females, it could be associated with infertility. You can have UTI and any other complication you can think of. Okay? So how do you prevent? This is the parasitic infection. So we always talk of prevention and control. Vector control is very important. If you don't have the intermediate snail, the life cycle stops there. Okay? There is no production of Saccharin. Avoid swimming in fresh lakes and rivers in endemic areas. So if you go on vacation, avoid swimming in these bodies of water. Proper treatment of an index patient will break the life cycle. So once an index patient is adequately treated, even if he or she refuses to stop urinating in the river, there won't be any eggs in her urine or in his urine, okay? Of course, health education is very important, and this is linked to safe disposal of human waste. Encourage people to have toilet facilities in their homes, discourage them from defecating or urinating in the environment. And of course, government can also show its commitment to prevention by providing potable water, because if you have potable water in the first instance, you won't be going to the river or stream to ease yourself. So there you have this article. Any questions? Yes. Pardon?
I don't think they usually keep like urine because that's when they urinate during the day.
The eggs, you are likely to find it when you collect urine sample within midday, between 10 a.m. and 2 p.m. Now, I said this is more of a parasite-host interrelationship, okay? You don't go swimming 12 midnight, do you? No, you don't. But during the day, you're likely to go swimming or to go there to do your laundry. So the parasite excretes or secretes the egg at a higher rate during that period. So that increases the probability of you depositing the eggs in the river and the eggs finding the intermediate host. Because there's no point for the parasite to produce the eggs and you don't micturate or defecate close to the body of water. There's no point because the intermediate host is found along the vegetation, with freshwater vegetation and what have you. Do you understand? So it's you know, I don't usually discuss this when I discuss parasites, but it's been shown that when parasites invade the intermediate host, they tend to change the behavior of the intermediate host to increase the probability of getting transmitted to the definitive host. I'll give you another example. With Toxoplasma gondii, remember that the cat is the definitive host, and then you have the small rodents as intermediate hosts. Now, some studies, some scientists have shown that intermediate hosts that are infected, they tend to be more daring when they see cats, increasing the probability of being eaten by the cat. So this parasite has an idea that during the midday activities are at its peak. So that's where it tends to produce its eggs, so that the chances of the miracidium getting to the snail intermediate host is higher. Yes, you're welcome. Any other question? Yes.
In terms of the diagnostic and the infective stages, diagnostic is the eggs and the infective is the septaria.
Exactly, very good. And the mode of transmission? What is the mode of transmission? Pardon? Skin penetration, very good. Any other question? So enjoy your day and take the attendance.